Brilliant, and thanks for your statements. Thanks, Helath. My first question is in relation to how many people have a neurological condition in Ireland at present?
Deputy, the estimate would be that there are over 800,000 people living with a neurological condition, which seems a huge number, but when you think about the vast range of conditions that we're talking about, anything from migraine, epilepsy, multiple sclerosis, acquired brain injury, stroke, Alzheimer's disease.
So I'm guessing that would be probably 1 in 7 people in the state?
And when you think about it, each of us knows someone, a family member or in our immediate circle has one or more neurological conditions. Okay.
And what would be the most common neurological condition in that kind of catchment of 800,000?
So the most common ones we tend to see would be acquired brain injuries, strokes, head injuries, these type, or then some of the more common neurodegenerative disease like multiple sclerosis probably would be the highest that we would see. But there are some that are maybe have a greater impact. So you've got migraine, which is a huge number. It's probably the biggest group that we see that maybe have a different impact perhaps than acquired brain injury and stroke. But ABI, head injury, stroke and MS are probably your biggest groups that you look at.
How many people would have MS, the condition of MS in the state?
So the best estimate is about 9,000, but if we look at the people with MS on the long-term illness scheme, it's probably 10,000, so it's a better estimate. But again, people with MS are diagnosed in their early 20s, so they're living with MS for a very long time, so that kind of multiplies it in terms of care needs. So that's the best estimate.
And in relation to treatment, and obviously you've stipulated in the statement in relation to that kind of multifaceted treatment, what would the common treatments for for a neurological condition obtain?
I think people with MS consistently come back and tell us that access to physiotherapy is their greatest need, followed by access to occupational therapy, vocational rehabilitation, psychology, neuropsychology. They would consider them the things that they need to do the things they want to do to live the lives of their choosing, and that's really where these multidisciplinary teams come in. Access to medications is another issue, but I think it is really that rehabilitation access is what they keep coming back to us as their greatest unmet need currently.
Okay. And I know MS Ireland have had a campaign around the National Physio Service. What difference would that make if that was implemented tomorrow, for example?
And again, this is an example of how the vocational, the charities are in that pathway, so from acute care to the community neuro rehabilitation teams and then on to the charity sector. So we had a successful Sláinte Care Integration Fund project that enables people with MS and other neurological conditions to access a physiotherapist-led programme. And the outcomes that are very significant. We see the changes that we would expect in terms of improvements in strength and improvements in balance. We see a reduction in the number of fallers and the number of people, the number of falls they have. So obviously the cost savings from that are very important. If one fall can cost up to €22,000, so if we can prevent 4 of those falls, we've paid for one of these physio posts already. We also have seen that people who engage with MS Ireland services, and again this is people with MS, stroke, Parkinson's, ataxias, various different neurological conditions, that they use the acute healthcare services less. So they are less likely to go to A&E, they are less likely to have an inpatient bed day, they are less likely to need their consultant. And I suppose a working example that pulls together the community neuro rehabilitation teams, the nurses, is a young woman with MS. She's in her early 40s. She has a deterioration of her MS. She needs a very specific medication for spasticity adjusted. The working example is our specialist MS physiotherapist in CHO2 working with the clinical nurse specialist in the hospital, making recommendations to the consultant. That was actioned very quickly, and within 3 or 4 days she has a new prescription for a drug without needing to go back into the acute system, without needing a consultant appointment, and the benefits from her are really, really life-changing in terms of her ability to do more things for herself and not need care. So that's kind of how it ties together. But in relation to MS Ireland's physiotherapy radiotherapy campaign, we're looking to roll out that Sláinte Care Integration Fund project nationally. I think that was what Senator Conway was referring to, and we're finding challenges with expanding that beyond CHO3, which is where our pilot project, and we would like everybody to have access to that, because the outcomes are very, very clear in terms of the benefit both to the people with neurological conditions, but also to the health services in terms of reducing the need for hospital care.
In an earlier statement, you said that 15% of neurological patients in Ireland have access to teams that provide vital care to support their recovery. So 85% are not getting the intervention that they need, and that's obviously a huge amount of people that just are not getting their intervention at that particular time.
And we're way behind international best practice. I mean, I would use the example of Belgium, which is, you know, a population of 10 million. They have 3 rehabilitation hospitals that just specialise in MS, and that's independent of their rehabilitation hospitals for everything else. We are so far behind internationally in terms of rehabilitation. The World Health Organization Rehabilitation 2030 strategy is saying that it's a basic right to have access to both inpatient and community neuro rehabilitation. We only have 1 rehabilitation hospital. We don't have those managed care networks that are put out in the rehabilitation strategy. This is one piece of the puzzle, and we are so far behind. And you know, there are world neurological rehabilitation conferences where people come back and present the data over and over again on their successes, and you know, we're one of those countries that is considered way down.
I'm sorry, and we are signed up to this. Ireland is signed up to the UNCRPD, which in an article encourages all states, or you know, the commitment is to provide rehabilitation services at all levels of the pathway. So this is something we've committed to as a country that we're not delivering on, as Professor Gouta says.
And why do you think that is? Obviously, the resources seem to be there. Obviously, there's a huge kind of retention and recruitment issues around the health service, not only in Ireland, across the world. But why is that? Why is it that Ireland's lagging behind, you know, the benchmark of Belgium, for example?
I think it's a commitment. I think there's a commitment needed to implement the neurorehabilitation strategy. There is a real commitment needed on behalf of these patients. It's not a recruitment issue in relation to the community neurorehabilitation teams, because we haven't seen the recruitment start for the teams around the country. Even ones that have been funded since 2020, we haven't seen recruitment start for those. So we're really talking about a lack of momentum, a lack of commitment to implementing that strategy, to meeting the needs of these patients.
I think many of these patients, we mentioned hidden before, but many of these patients are not seen. They're just not seen. Their needs are not seen. They're not being recognised as being treatable, I think, in some way. I mean, if you think of any other illness, you know, we've seen an amazing development of oncology and cancer care services in recent years across the country. We haven't seen anything like that in brain injury. And if you can imagine going into a hospital with a diagnosis of cancer and being sent away home on your own to try and find your own treatment or find your own radiation oncology centre, I mean, it's unthinkable nowadays. And yet we're at that point with people with brain injury. They're being sent home and nobody's seeing them and nobody's seeing their needs. And this is part of the problem.
Okay. My final question is in relation to the Medical Cannabis Access Programme. So obviously the Medical Cannabis Access Programme was instigated 4 years ago. At present, there is about 47 people that have got a prescription under the Medical Cannabis Access Programme, and I understand the vast majority of them are for MS with spasticity. And also there is the development around Sativex. Sativex now is being reimbursed, which is a good thing, because people that were trying to get Sativex had to go either up to the north. It's quite expensive medication. Now in Denmark, for example, the Medical Cannabis Access Programme includes a lot of neurological conditions where actually cannabis can be very, very beneficial. The access programme we have here is very restrictive. There is a review going on at the moment, and hopefully that it will expand to other conditions, particularly around chronic pain and neurological conditions. So I just wanted to get your thoughts on that.
Thank you, and I have a briefing in front of me just, and we're delighted to see that Satisfax has been recommended for reimbursement through a managed access programme. It's a start, as you say, it could be rolled out further, and I think for people with MS, its primary use is for people with moderate to severe spasticity, so stiffness in their limbs caused by their MS. So we're delighted to see it's there, but obviously it's a start. It's the start of the greater access to this drug, because there is very good evidence to say that it is beneficial, as you say, for a range of different impairments or different symptoms of a range of different conditions.
Okay.
We would certainly encourage that review, because that is the feedback we're getting from our other member organisations, that they certainly feel there could be more done with the managed access programme for conditions, as you say, like epilepsy, like chronic pain, that there could be a broader access there. So certainly encourage that timely review. Yeah,
and I understand that review is happening, and it will come back to the Department of Health with its recommendations very, very soon, and hopefully people can get access, because I know people, and you might know people that have, say, a neurological condition, and some people have to go to the black market, some people have to go abroad, or worse still, people have to go out. Now, I just don't think that's acceptable, where, something that has, good kind of medical benefits, that people are denied that, and they shouldn't have to go to the back market for that. So hopefully with this review people can get access legally rather than illegally. And it does go back to the broader resourcing of these services as well, because people need to be seen in order to identify the treatments that they need. So we're seeing still really, really long and lengthy waiting lists for neurology services. We've over 23,000 people still on neurology waiting lists. So, people are waiting longer time between appointments. They're struggling to get access to a specialist nurse. So even to get to the point of diagnosis, and to be able to see those health professionals often enough to be able to be prescribed the medications that you mentioned, we're just seeing that it is a symptom of the under-resourcing of neurology services as a whole. Okay.